Assalamu alaikum, Mr. Khair. Good evening, everybody. My name is Sbeih. I'm a neurosurgeon, and we are transmitting live from Farah Medical Campus here in Amman, Jordan. Our topic for this night is a posterior fossa tuberculous lesion. We will discuss the clinical, pathological, operative, and pathological correlation. So before we start, we have to know something about tuberculosis, which is a worldwide health problem. In developing countries, 110 to 165 cases per 100,000 population per year, while in developed countries it's much less. 2013 WHO report says that 9 million people developed TB and 2 million died of that disease. So tuberculosis has resurged with the outbreak of AIDS and increasing frequency of other immune-compromising conditions. There is resurgence of tuberculosis. It's no more a forgotten disease. It is very much to remember it. If we look at these publications, old enough, 78, 89, 95, from Spain, only 3 patients developed TB in an HIV-positive patients, and these are the papers. 1 patient in France, 93. So there is a global increase in the incidence of tuberculosis, both in the immunocompetent and in the immunocompromised. And unfortunately, 70% of patients are below 20 years of age.
Partially that's because of the multi-drug resistance.
Yes, of course.
Change the sign about 20 years, less than 20 years.
Yes, less than 20 years. So why is that? Why do we have resurgence of TB in developed countries in the last 10 years? Immigrants, lots of camps, poor sanitation, poverty, immunosuppression, HIV, alcoholism, aggressive chemotherapy, increasing age, and drug resistance, as Dr. Marwan Khoury just alluded to. Here in Jordan, the first hospital to treat tuberculosis was built in Karak, 1890. And we have to remember the Italian hospital, which was established in 1927. When you mention tuberculosis, everybody remembers Zeal, Nelson, Stein. But I'm sure we write it wrongly. It's not Nelson, it's Nielsen. Franz Zeal is a German bacteriologist, and Frederick Nielsen, also a German pathologist. They combined this Zeal, Nelson, Stein for tuberculosis. So, Rahman, تفضلي. So to give you an introduction about TB, it's much better than I. Dr. Balvisi, please.
Thank you very much. Good evening, everybody, and welcome to our international audience. One could talk about TB for hours and hours, if not days, but I'll try in 10 minutes to give you a capsule of what we need in clinical practice. So this is an image of a macrophage trying to swallow mycobacteria. They can swallow it, but they can't kill it. And there are many, many mycobacteria. Mycobacterium TB is only one of them. And so when we say AFB positive, we don't really mean Mycobacterium TB. It could be any of the ones that you are looking at. To start with infection control issues, because that's what you need to know before you walk into that room with a suspected TB patient. Transmission is airborne, it's highly contagious, highly transmittable. If I cough at this end of the room, all of you will get TB infection or at least be exposed. So we like to isolate all suspected patients. We continue with isolation for those that prove on chest x-ray to have open cavitary disease or vocal cord disease. We put them in negative pressure rooms, otherwise known as airborne infection isolation room. And here at Farah Medical Center, we have two. One on the 7th floor, on the 4th. We have 4 rooms. Clara is our infection control officer, and 2 in ICU. So we are ready if we get a case of TB.
Most hospitals don't.
And then most hospitals may not have it. Right. And even given that negative pressure, we like the patients to wear a surgical mask. We ourselves walk into these rooms wearing special masks, the N95 masks that filter 97.7% of these particles. These particles are small. That's why they travel far in the air. There are special respirators that we used to use at Mayo Clinic. They're still used worldwide. And we used to do fit testing for masks so that a person, you fit it to your face to make sure that bacilli do not enter and cause disease. And a contagious patient is a patient with a positive sputum for AFB, and contagiousness ends when that sputum becomes negative for AFB. Typically, it takes 3 weeks of effective therapy, about day 21 to day 22, for a smear to become positive, and we call that seroconversion. And that's when we can let a person out of isolation because they're not contagious anymore. The natural history of TB, we get exposed to empty bacilli. 90% of people clear the organism, 10% of people get infected. Of those, 90% go on to latent disease and 10% go on to progressive primary disease. Here's where basilemia happens, and then the bacilli spread to the liver, to the brain, and cause illness later on. Secondary TB can be seen in reactivation of latent TB infection and may cause cavitary and caseation disease, and may also cause extrapulmonary disease. So there's pulmonary, there's extrapulmonary. So it could go to bone and joints, in the spine, Pott's disease, very famous. We see a lot of peritoneal. I've seen a lot of peritoneal TB here in Jordan, renal, biliary disseminated pleural, or CNS disease. And that brings us to our topic of the day. The CNS TB can manifest in 3 forms. So it could manifest as meningitis, basal typically. Could manifest as intracranial tuberculomas, masses in the brain. And it could manifest as a complication of TB, which is hydrocephalus. There's also spinal TB when we talk about CNS TB, and choroidal TB in the eyes. So as bacilli invade the blood and they go everywhere in the body, including the brain, scattered tuberculous foci are established in the brain, meninges, or adjacent bone, and the chance occurrence of one of those subintimal tubercles bursting into a subarachnoid space ends up in a case of meningitis. Reactivation happens in old age due to alcoholism, malnourishment, but also due to immune suppression at any age. So HIV positive patients, patients with malignancy, chemotherapy, steroids, and TNF-alpha medications, rheumatoid and the like. I won't go into the pathology as Dr. Fossa, I'm sure, will discuss that. A differential diagnosis of a CNS tuberculoma would include fungal meningitis, which can cause focal masses, and we're talking about cryptococcus, as well as histoplasma, blastomycosis, and coccidioidomycosis, which are endemic fungi seen in certain parts of the world. Viral meningoencephalitis, herpes and mumps, parameningeal infections, partially treated bacterial meningitis, neurosyphilis, a forgotten disease, another forgotten disease, neoplastic meningitis, lymphoma or carcinoma, neurosarcoidosis, and neurobrucellosis. Shortest way to a diagnosis of TB meningitis, obviously, is CNS analysis. There's high opening pressure, leukocytosis with lymphocyte predominance, low sugar and high protein, more than 500 to 1,000. So that makes you suspect the case of TB meningitis. You send the AFB smear, and that's what the microbiologist will see. On a background of blue, you have bacilli that are fast, acid fast. They kept the acid, and so they kept the color red. This has a high specificity and predictive value. Disadvantages is that you need in the sputum a lot of them, and I thought this was interesting for you, because in the sputum you need at least 5 to 10,000 AFBs per mil, so before you can see them. And that's why a more sensitive stain, the auramine rhodamine stain, which requires a fluorescent microscope, is sometimes needed. You see the bacilli as fluorescent orange or green against the black background. Very easy to diagnose. All this tells you is what? AFB positive mycobacteria. They could be MTB or non-tuberculous mycobacterium. So cultures, of course, the Lowenstein-Jensen solid media is an age-old solid medium. The problem is that these bacteria have a slow generation time. They are slow to divide. Typically, bacteria divide quickly, 2, 4, 8, 16, blah. But here, it takes almost a whole day for it to divide. And so cultures take a long time on solid media, 2 to 6 weeks. They take a shorter time in liquid media, 2 to 3 weeks. And after that, the lab will call and say, we have a growth of an acid-fast bacillus. Is it MTB? Well, we can't be sure. We have to do more testing to confirm that it is TB. And I only stress this because through 20 years of practice, I've seen many misdiagnosis or confusion about interpreting initial lab results. Molecular diagnostics are here to help. They are rapid, and you can look for the nucleic acid with amplification of NAT, speciate, look for resistance genes. The gene expert can tell you what the mycobacterium is, or at least if it is Mycobacterium TB, and if it's resistant to rifampin or not, which is a key anti-TB medication. You can get all that in 2 hours. That's medicine in the modern age. To wait for 6 weeks for something to grow is totally ridiculous in this day and age, to say the least.
You can do that on the sputum sample immediately.
Yes, you can do that on the sputum sample immediately, Marwan says. Thank you. And PCR, we can also do that on the sputum sample, on CSF, and that's available to us.
Available in Jordan?
Yes, yes, it's available in Jordan, yes. So we routinely now ask for TB by PCR from the CSF. When we try and get it, we can do it on pathological specimens. The molecular technology can help you, tell you if there's resistance, for example, INH or rifampin. Marwan alluded to the problem of multi-drug resistant TB, and there's also extensively resistant TB, which we'll talk about a little more towards the end. So you use your physical exams, skin test, I'll jump to it. This is old age, the PPDs, tuberculin mental, TB skin test. So you bring the patient in, you do the intradermal injection of the TB mixture, which is a really old mixture. It's a mixture of many antigens. But if the patient's macrophages and inflammatory cells have seen TB before, they will produce interferon and they will attack and form a mini granuloma. And you see that as in duration at the site of injection. You want to read this at 24 to 72 hours. So that's 2 visits for your patient. So they may come back, they may not. And so I prefer the IGRA, which is interferon gamma release assay, where you take the patient's memory T cells and you incubate them with TB antigens in the lab, in vitro, outside the body. And if these cells had seen those antigens that remember produce interferon, you can measure that and you get a number. And you can get this out in a day. It's more expensive, but good medicine is expensive medicine. Then we move on to radiology. So you see the cavitary disease. CNS, these are all examples of tuberculomas. They may have, you might have one tuberculoma or more. You make a calcification. Brahim has helped me consolidate these slides, I see. And you can also get hydrocephalus and suspect TB. Moving on to therapy. So you want to use first-line agents that have good penetration into the CSF. Examples be isoniazid, rifampin, pyrazinamide, and fluoroquinolone, moxifloxacin, or levofloxacin. Second-line agents are available in case of resistance. These are old, archaic drugs that we hate to use because they have many, many side effects and they have to be injectable. So we don't use them except when we're forced. Luckily, the pipeline has produced some newer anti-TB medications. Bedaquiline, approved for TB treatment. Linezolid covers TB, and there are some more coming our way. Principles of therapy: intensive therapy for 2 months, just like pulmonary TB with 4 drugs. And then a continuation phase of 2 drugs for at least 9 months. You want to do at least a year with CNS TB, and sometimes even more, a year and a half or 2, depending on the situation and the susceptibility of the bug. And so this is where we get in trouble, because in 20 years, I've yet to see a lab report that tells me sensitivity of a TB in Jordan. I don't see it. The Ministry of Health will say, oh, send it to us, we'll do susceptibility, which, you know, well, fine, welcome, we're happy to do it. I've never seen that report come back. So I don't know what happens there, but we really do need that susceptibility data to base our treatment on choice and duration.
So we can't say anything about MDR prevalence from your experience. Is MDR TB a problem in Jordan or not?
It's not a great problem in Jordan, but as it happens in medical practice in Jordan, we see many patients that come from other countries where MDR is a problem.
Arab world, let's say Yemen.
In regions of the Arab world where wars have taken ravage and broken down the healthcare system, such as Iraq, Yemen, Libya, and we've had patients from these countries, and so that's where one would suspect a case of MDR.
Actually, one would make an argument this is where you'd expect surgeons of TB, not necessarily MDR.
Absolutely, absolutely. Amongst many other terrible infections like cholera. The biggest outbreak in history ongoing in Yemen.
And you already mentioned something about that. I'm glad that you just brought this up to our international.
Yes. And survival depends on that resistance. If you look at this slide, you see that a fully sensitive patient with a fully sensitive TB has better chance of survival than a patient that has, for example, monoresistance to streptomycin or INH or both. Steroid use, we like to use steroids in the CNS to decrease the inflammatory component of the illness. There's the infection and then the inflammation. I'm not going to go through this, but we almost always use steroids treating TB meningitis. I'll just kind of close up with challenges to TB eradication. Why have we not eradicated this age-old disease? One, there's lack of protective vaccine. The vaccine we have is ancient, and just a collection of antigens, and so we need a vaccine that stands up to modern scrutiny and gives us protection. The BCG protects for the first year. We typically give it to our infants to protect them from TB meningitis in the first year. There's no evidence that it continues to protect much thereafter. Inadequate and slow diagnostics, lack of effective modern anti-TB medications, the MDR problem referred to, and the HIV epidemic, of course. And so when we have better diagnostics, we're able to improve the survival. If we have better treatments, we'll improve the survival even further. If we have both, we'll improve it almost to an extra 250,000 people surviving TB each year. This is the incidence of TB around the world with concentration in Africa. This is the incidence of MDR TB with concentration in the former countries of the USSR Russia, and the neighboring countries. It's estimated that 500,000 people around the world have MDR-TB. And so TB care reimagined would be a situation where we'd have a new vaccine, be able to rapidly triage patients, rapidly diagnose patients with Maladitov and the like, give short, effective treatments. Currently, studies ongoing for bedaquiline, predominant moxifloxacin and pyrazinamide, monitor adherence through electronic means, and support patients. And hopefully we'll see this soon. And so with this, I will stop and give the mic back to Professor Bryan.
Thank you. So it's a worldwide problem, and we face it, and we have to learn more about it. The organs affected, as I said, lungs first, lymph nodes, osteoarticular joints, spine, abdominal, intestine, like enteritis and peritonitis, genitourinary with their kidney and urinary bladder, and of course, our topic for today is the CNS. So this is pulmonary TB, Bahima, as we mentioned. And this is a paper from Taiwan, Resurgence of TB. We have to admit that TB is no more gone, it's there, and it is vigorous. Lymphadenitis in the neck, osteoarthritis in the knee, testicular tuberculosis, ocular tuberculosis can affect any organ in the eye, any layer in the eye, iritis, iridocyclitis, vitritis, retinitis, choroiditis, vasculitis, optic neuritis, ophthalmitis, and panophthalmitis. The commonest in the eye is uveitis. And the commonest of the uveitis is not the anterior or intermediate, it is the posterior uveitis. It's very common in KSA, Saudi Arabia, 16%, while in USA it's 1%. But look at this paper from Boston, USA, of this ophthalmic experience in TB sanatorium in Boston, 10,000 patients, 15% intraocular. But that's a long time ago, 1967. Intraocular tuberculosis in this paper, 2010, again from USA. Tuberculoma, look at the scar of the tuberculoma. Again, tuberculoma choroiditis, exudates, and everything. And this is a very nice paper, 2013, I think from India, and it is about 1,000 consecutive HIV positive. Remember, we were saying TB resurgence with HIV epidemic. 1,000 patients who had HIV, and look at the ocular manifestations. Case of endophthalmitis from Japan, developed country. Another one, again from Malaysia, with choroidal tuberculoma. Panophthalmitis, 2016, from Thailand. Post-cataract endophthalmitis due to TB, post-surgery from Mumbai, India. They can mimic tumors. Intraocular tuberculosis mimicking retinoblastoma. This was thought to be a retinoblastoma when they inoculated the eye as TB. Spinal tuberculosis, and I'd like to call upon Dr. Zaid Zabi to tell us about it.
Thank you, Dr. Ibrahim. Dr. Ibrahim gave me 10 minutes to talk about spinal TB, and actually, because I mean, all things related to pathology, physiology, anatomy, and so on has been discussed. So I'm going to tell you about some rare cases of spinal TB and some tricks in treatment of TB spine, including the surgical and medical. Okay. Well, spine is number one actually site of hematogenous osteomyelitis in adults, and third and most common site for all age groups. And the organism is nothing actually. The environment is everything, as Pasteur tell. Environment means original injury, original organ, host's ability to neutralize bacteria, and the vascular environment, surroundings, hospital, staff, and so on. Spinal infection, either post-operative, like post-discectomy, spinal fusions and instrumentations, or acute pyogenic in childhood, adolescent, and adults, and the chronic granulomas like TB. This case actually is extremely rare. This is the only case I have seen. Is this HIV bone or spine? This case actually, this patient called Miftah, he came from Libya. He is one of the victims of the injecting HIV virus to children by a nurse from, I think, Bulgaria or something like that. So it's extremely rare, and we could not actually do nothing for him. He died a few days after I have seen him. Well, actually, because of, the relation between the vascularity of the spine, and the related organs or neighborhood organs, the hematogenous is coming through this spread, in spinal artery, via spinal artery, and drained via paravertebral venous plexus, and also can spread directly, or from surrounding organs. TB spine is usually, not all the times, is affecting the disc and the neighbor vertebra. So when you see destruction of the disc and surrounding, the vertebra above and vertebra below, it's TB unless otherwise proved. While in trauma, the arterial system in the spine is responsible for most of the cases of infection. It's rich blood supply and penetrate the end plate 180 degrees to the metaphysis, and there's a special venous system of Patsom, called Patsom. It's from pelvic and abdomen, vertebral arteries to thorax, valveless, the veins are valveless. So it's direct, invasion from the surrounding organs, whether from intestine or from the lungs to the dorsal spine. Of course, medical treatment, most of the cases underwent surgery or CT-guided biopsy were found to be mixed. Almost all the cases I have seen, it's not only TB bacteria, but it's mixed with another bacteria, especially in the last 2 decades. Probably that TB has disappeared for some time from many countries and reappear again because of probably low immunity, HIV, and so on. But most of the cases we have seen is mixed with another bacteria. Of course, that's why culture analysis is mandatory before starting anti-tuberculosis and antibiotics. The operative treatment, the approaches is different according to the vertebra affected. In cervical and dorsal, the anterior approach is much better, of course, and there is severe, when there's severe instability like this one. And also, if you go from posterior, there's high incidence of cord ischemia and causing paralysis. And I've seen actually many cases of treatment of infection in the spine, the vertebral bodies and disc, going from bilaminectomy and so on, and trying to move the cord to reach the pathology. So and why they go from posterior? Because anterior usually is not easy for most of the spine surgeons. In case of lumbar vertebra, it's completely different because you can mobilize the dura in lumbar vertebra, especially the lower lumbar vertebra. This is a case actually like this one. This is Rasha Mahdi. She came from Yemen. Okay, she's around 15 or 16 years old, and her father is a professor in medical school in Aden, and she has actually destruction of the, as you see here, of the vertebra, the disc and the vertebra above and below, and she was actually paraplegic and almost paralyzed of the lower limbs. One of the best things around about TB spine, that if there's weakness of the lower limbs or paraparesis or something, it improves dramatically after you do surgery. If you do correct surgery like this one, we have done anterior approach. We remove the whole pathological vertebra here and replace it by this cage. At that time, actually, this is a long time ago, 1998. At that time, we did not have the screws for the dorsal spine, only the lumbar spine. So we fix it by hooks from the posterior. So this, she has anterior and posterior in the same session. And she improved completely. And she came actually after 6-7 years with her father. She's married and normal life. I select, some cases here. If this dorsal, sorry, you cannot mention. Okay. This is actually probably we missed the slide, the pathology. This is cervical. And again, we go from anterior, we remove the whole body of the vertebra here, and fix it from posterior also. At that time also, we did not have the plates to fix, above the cage. This is interested. Saleh Jawabra, he came from Palestine, actually, as old man, 70 years old man. And he has, as you see here, abscess anterior to the body of the vertebra. And this destroyed the discs, vertebra above, vertebra below. And it caused for him also almost paraplegia, weakness of the both legs, because it's level 3, L3 is on. So we go from anterior, we remove it. And at that time, actually, we did not have cages in Jordan. So we remove it and we did for him posterior fixation. We put as alternative here, you piece here, as you see it, this is a rib. We excise the rib and put it here. And this, again, patient improved dramatically. This is very difficult case because it takes destruction of the whole L5. And if somebody tell you that, TB can destroy the bone, only the disc and the bone above and below, this is not good. Because, as I told you, all these cases were mixed bacteria, not only TB, but TB mixed with another bacteria. And this is actually difficult. Why difficult? Because, to go anterior, as you know, where the anatomy is very difficult. Iliac arteries, iliac veins, and so on. So, and plexus for nerve plexus. So, again, we remove it from anterior with the help of vascular surgeon, and we fix it from posterior, from S2, because we have to remove part of the S1, and also remove the whole thing and put, again, this is, of course, Mariam Abu Rukba. This is the only Jordanian patient of the series. Again, very beautiful girl, this one. She married and she has children also. We prefer surgical treatment rather than to stay on anti-tuberculous drugs for a long time. Why? Because sometimes there's, the strong indications, sometimes there's cold abscess, you have to do drain it as any abscess. And when there's neurological symptoms and signs, and where there's failure of medical treatment, the advantages avoid permanent neurological complications and fast recovery and antibiotics according to the culture and sensitivity. Yes, thank you.
So we'll come to the topic for tonight, the cranial TB. How can tuberculosis affect the brain and surroundings? Can affect the meninges, which is the commonest, 70-80%. Can cause tuberculomas, masses in 30-20%, and in 10% or less, you can have tuberculous abscess. So this is tuberculoma in miliary TB. This is meningeal enhancement in form of meningitis. And again, the basilar meninges. So meningitis is exudative, and especially in the basal cisterns, it can cause lots of adhesions. Look at this, and the basal meninges. So that's why they develop hydrocephalus, because it will block CSF pathway. And hydrocephalus in TB could be communicating, could be non-communicating, obstructive or non-obstructive. Various cases of hydrocephalus secondary to tuberculosis. And because of the meningitis, you will get a process called endarteritis obliterans, where you get the pathology inside the arteries and they will close. So middle cerebral here is closed by TB. And this would lead to infarctions. Look at this. Infarctions could be unilateral, could be bilateral, secondary to tuberculous meningitis. So it can kill. And we mentioned that 2 million people die annually out of TB, mainly if they develop CNS infection. So this is the pattern of infarcts in the basal ganglia. From India, you can see bilateral infarct. Again, infarctions from South Africa. South Africa, by the way, they have one region, I think it's in the north. It is the largest number of patients with tuberculosis. And we know that they have HIV positive patients as well. Cranial nerves can be affected because of the basal arachnoiditis. This paper again from India. So you can see why we are affecting here. You can affect the fourth nerve, you can affect the third nerve, and here you can affect the seventh nerve. And this is how the imaging would look like. A paper from Portugal, hydrocephalus, basal arachnoiditis, everything. The same thing, hydrocephalus. Or you may get cerebritis. Cerebritis is just inflammation, encephalitis kind of thing. So you get a stage of cerebritis, like this. And then this may develop into tuberculoma, a mass, which could be single or multiple small or giant, like this, multiple small. It could be giant like this. And with this, you send it to a report, and people would say the first thing is parasagittal meningioma. Well, parasagittal lesions are so many, not only the parasagittal meningiomas. Various kinds of tuberculomas, small and large. Look at this here. You may miss it for a glioma. And they can get calcified. We are forgetting about the value of a skull X-ray. No more people are asking for a skull X-ray as a preliminary test. It can give you a lot of clues, especially from the cellular area. So they can get calcified. And they get what they call target sign, just like the target, because of the calcification, whether CT or MRI. And here again, another tuberculoma. You can get extradural, epidural tuberculoma. This is from Paris. I looked deeply. The patient is not French. He was of Moroccan origin. And the use of spectroscopy in these cases. Tuberculomas can also be in a very unusual locations like intraventricular, supracellular, and this was in the cerebellum-montane angle. The commonest lesion in the cerebellum-montane in the frequency is vestibular schwannoma, meningioma, epidermoid. But people forget about the other manifestations of other lesions in that area. Again, supracellular area. This is the multiple tuberculomas that can develop into an abscess, 10% of cases. So tuberculous abscess. And I also looked into the literature. In USA, in these early years, they mentioned 3 patients who developed abscess secondary to HIV. Pictures of various abscesses. Look at this. You can say this is bacterial abscess. I mean, other than TB, etc. They can be multiple. And this is a very interesting paper from India, from my friend Atul Gul, flare-up of tuberculous abscess following stereotactic aspiration. I've never believed in just aspiration of an abscess. I believe in accession of the pus and the capsule. The capsule contains the organisms and you have to get rid of it. Again, brain abscesses in AIDS patients, unusual places, parasagittal, multi-resistant drugs cause these, again from USA 2003. looking into the paper, he is a patient from Yemen. This is a paper from Mexico, and also in immunocompromised and immunocompetent. So this is in immunocompetent from Mexico. Look at these abscesses. You can have extradural abscess with osteomyelitis of the bone, like this, extradural or subdural, like this. And again, subdural empyema like this in an infant with osteomyelitis from Turkey. So now come with our presentation for today, which is going to be easy now for you. This is a patient, 31-year-old from Yemen. He came with a 3 months history of vertigo and unsteady gait. And then also he complained of headaches with diplopia and nausea. Nothing in the past history, just appendix long time ago. And I wanted to say this because there's no history of TB in his family, and he had no TB in his body anywhere else. So this was a primary tuberculosis without pulmonary TB in him or in his family. Vital signs were okay. He was not feverish. General examination was normal. Glasgow Coma scale 15/15. He had sentinel palsy. He was closing his right eye because when you see double vision, you try to close one eye to see one vision. So that's why he has this appearance. His facial nerve was intact. He had tandem walking impaired. He had wide gait. He had imbalance. Yet the power in his upper and lower limbs were normal, right and left. That's the patient, and we do this photo to say that he does not have pyramidal weakness. If the patient raises his hands like this, and there is no drift, this means that he has no weakness. Very quick examination. We keep telling nurses, Glasgow Coma scale, you can do it in 1 minute. So easy. Investigation, chest X-ray, ECG normal, CBC normal, bleeding time normal, kidney functions, electrolytes normal, liver functions, we have just elevated GGT, mild elevation of ALT. Imaging, and I would like to call upon Dr. Ahmad Atami to tell us.
مساء الخير. This is the axial view post contrast for the same patient. If you look carefully, before starting to describe this image, there are 3 things you have to look as a radiologist before interpreting the image or to analyze the image. First of all, you have to look for the basal system and even if there is any enhancement. Second one, you have to look. Second, you have to look if there is any communicating hydrocephalus. And third one is secondary hemorrhagic infarction or infarction due to vasculitis. If you look carefully in this T1 post contrast, there are multiple basal cister enhancing, nodular enhancing lesion. Also, we have in the right cerebellar hemisphere multiple miliary enhancing lesion. The lesion causing some mass effect upon the fourth ventricle, but still this is patent. Next one. This is T2 axial view for the same patient. If you look carefully, there is a large hyperintense mass lesion involving almost all the right cerebellar hemisphere, extending into the right cerebellar peduncles and reaching the right CP angle, causing the midline and causing some compression into the fourth ventricle. I can't see the ventricle if there is any hydrocephalus. Next one. This is post-contrast also. You can see this is the enhancement of leptomeningeal enhancement and some medially enhancing lesion within the cerebellar hemisphere, also in the CP angle. The same, you can see here the compression into the Sylvian aqueduct and the extension of the tumor to the left side. This is also T2 weighted axial view for the same patient. We can see the same findings, also this extension into the brainstem. This is flare sequence. Flare sequence is very important to diagnose the leptomeningitis because in flare sequence, turbos FLAIR sequence, there is no suppression of the CSF because there is a proteinaceous material within the subarachnoid space. This is very diagnostic. Next one. This is coronal view. We have some prominent of the frontal horns of the lateral ventricles. This is the lesion, enhancement of the meninges, miliary enhancing lesion within the cerebellum for ventricle. Also coronal view, the same findings. This is a spectroscopy, single voxel spectroscopy sometimes can help because it's a inflammatory process and we look for the lactate. Lactate, this is the spectroscopy. This is part, this is ppm, part per million, and this is the concentration. If you look carefully here, we have this peak lactate at the 1.4. If this is to know if it's a lactate or it's a lipid, because lipid is very close to the lactate, it's about 1.3, this is 1.4. We have to do TE 280 and then 150 to invert T lactate. The next one. If you see, this is inverted, which means this is lactate. Well, lactate is increased in inflammatory process. But this, the choline and NA is not specific for this lesion. Also, as I mentioned before, you have to look for MRA in order to see if there is any vasculitis and secondary infection. If you look carefully, this is the right vertebral artery, left vertebral artery, basilar artery, posterior cerebral artery. This is the internal cerebral artery, canal. This is the middle cerebral artery, anterior cerebral artery. Grossly, there is no any significant narrowing. Vein. Also, the TB can cause superior sagittal sinus thrombosis, and we have to look carefully. If you look carefully, this is the superior sagittal sinus spatans, sinus, and this is vein of Galen. And also we have the transverse sigmoid. Grossly, there is no evidence of superior sagittal sinus thrombosis. To summarize our findings, there is a hypointensive T1 weighted, hyperintensive T2 weighted, and enhancing lesion within the basal system, which is very important. The differential diagnosis in this regard, first of all, you have to put in your mind is sarcoid, inflammatory sarcoid. Also, we have infection meningitis. Or you have to keep in mind also if there's a history of rheumatoid arthritis can cause this pattern. Thank you.
So we did surgery for this patient, and some of you may ask, why did you do that? It looks like TB. I will give you the answer later. Differential diagnosis of such a lesion. Remember the lesion again, keep it in your mind, and compare it with the lesions I'm going to show you, and tell me if there is any difference. Medulloblastoma, 4 types. Some people put it into 5 types. Similar or not? Very much so. Cerebellar metastasis. Cerebellar metastasis, whether from melanoma or others, hemangioblastoma, infiltrative medulloblastoma, ependymoma, hamartoma, they all look like our lesion. Ganglioma, juvenile astrocytoma, NF1, atypical teratoid, dysplastic ganglioma, astrocytoma, and most of these are my cases. So they have been histologically proven. Cerebellar infarction, cerebellar tuberculosis is on the list. Medulloblastoma, cerebellar encephalomalacia, Lermit-Douglas disease. So many differential diagnoses. And because we have a patient who is progressively deteriorating with building hydrocephalus, sixth nerve palsy, and shift of the fourth ventricle, we have only one option, is to firmly diagnose by either biopsy or by excision. Ala Adasi is oncologist, hematologist.
Thank you. So what is an oncologist doing in a TB session? Well, this is exactly why we're here. These are actual cases. This is not just a mental exercise of what could this be. And the difference is tremendous in the approach to all of these. Medulloblastoma as top of the list. After total excision, if possible, the mainstay of therapy would be radiotherapy and then plus minus platinum-based chemotherapy, and the treatment would be potentially curative if dealt with properly. Now, metastasis in this region, it cannot be emphasized this enough, and you'll miss that because nobody bothered to looking for a primary on this patient, and nobody did a proper breast exam and a decent physical examination to rule out this. In a patient where you could have easily dealt with melanoma because nobody bothered to check the skin properly and examine the skin properly, including hidden areas between toes, below the nails, etc., etc. Now, ependymoma would be treated after surgery with, again, with platinum-based chemotherapy after radiotherapy. The chemotherapy of ependymomas and medulloblastomas tend to be similar. Now, gangliomas, the mainstay would be really surgery. Astrocytomas, it depends upon the grade of the astrocytoma, but after complete surgery, they may be followed by radiotherapy or alkylator-based therapy or both. Cerebral tuberculoma, we mentioned that. We mentioned the possibility of sarcoid being this, and the approach would be radically different, and sarcoid would disappear if somebody just gave them steroids before that. Infarction and encephalomalacia would actually have, will have no implications from an oncological perspective. These are actual cases. Now, the other reason that I really have to emphasize, we tend to forget that we are living in an endemic area for TB. And TB can flare up with steroids, it can flare up with chemotherapy, it can flare up with almost everything we give, regardless of whether they're directed to TNF or not. And regardless of the MDR TB incidence in the world, we are living in an endemic area for TB, and we should not forget these lesions.
We did a few consultations. We consulted the ophthalmologist, Dr. Ibrahim Sadat, and here.
Good evening. So obviously, from the notes, TB did not affect the eye. Everything is okay. It affected the sixth nerve palsy because the right sixth nerve passed through the cerebral pontine angle, and there's hydrocephalus. So any of these could affect the sixth nerve palsy. Also, there's direct affection of the sixth nerve palsy. Usually, these patients come with diplopia. It's a vertical diplopia which increases towards the side of the lesion. So he sees two here. He sees less separation, and probably this is one. This is one. And sometimes they close one eye to see better. Otherwise, they will feel dizzy. They might vomit. They will have headache.
Thank you. At that time, Dr. Jamal Sharif was in charge, and he announced the patient to be fit for general anesthesia. And in this case, like other cases of Fossa, I do them in the sitting position. Dr. Faraz, are you around? Dr. Faraz Baisha is the chief anesthetist in Farah, and he is with us in many cases of sitting position.
Thank you, Dr. Ibrahim, for the very interesting cases over and over again. And they are challenging as well. Dealing with a patient coming with TB is extremely serious condition and extremely challenging for the anesthetist. The implications for anesthesia can be divided into three major classes. The first one is the patient general condition in general, because this could be pulmonary and extrapulmonary, as Dr. Muntasar Bilbisi has stressed out. So the patient could be symptomatic, they could be really sick patients. The other is that the universal precautions for being infected as healthcare providers dealing with a patient with TB. The third one is has the most serious implications for anesthetists, especially for patients who had received TB treatment, especially rifampicin, isoniazid, and so on. because these drugs actually has some very serious effect on the liver. So we as anesthetists have to be extremely aware of the liver function test, because rifampicin, for example, and isoniazid are liver enzyme inducers, especially cytochrome P450. And this has some very serious effect on the anesthetic drugs, because these patients have very high consumption of opiates, and they have very high consumption of muscle relaxants, especially rocuronium and vicuronium. And dealing with a sitting position patient, these patients are on continuous muscle relaxant infusion. And usually we use, in most patients in the Arable, because we have different pharmacokinetics and pharmacogenetics, we use a lower dose than the European and the American population. But for these patients, we have to be extremely cautious, because if any movement would cause tetraplegia in the operation. So we have to be aware that these patients who have tuberculosis, they have very high consumption of muscle relaxants and very high consumption of opiates, especially due to the induction of liver enzymes, especially cytochrome P450. The other is that some of these drugs can cause serious hepatitis. And if these patients are diagnosed with hepatitis, the mortality could reach between 5 and 10%. Thank you very much.
I'm proud to say that we are one of the most experienced people in sitting position in the world. I'm saying this in a loud voice. We are one of the experts doing this kind of surgery in the sitting position. The patient is sitting, and I'm also sitting. The one who really tires is the scrub nurse and assistant. So this is the view you want to see, sitting position. We are looking from behind. This is the right cerebellum, this is the left cerebellum, and we'll be going here. And we go here in transverse fashion between the foliae of the cerebellum, not this way, because you'll damage lots of foliae, you go this way. And we get the extensive consent, spelling out everything about patient and the complications. And we'll see the surgery now in the video. It's gonna be quick film, so don't worry. So as I said, patient is sitting. This is midline, this is left side, this is right side, this is cisterna magna. I'm doing the transverse section, I'm going into the tissues. Here I am. You could tell this is abnormal because it is tumult, it is just elastic, and this is not the normal brain. Normal brain is not. So we take as much as we can of that lesion. In the first minute we got the specimen, we send it for a frozen, and we continue. Again, if I'm there, I'd like to take as much as the lesion as I can.
Is it well encapsulated?
No. So this is the cavity left. And we do hemostasis. We put this hydrogen peroxide thing, which would coagulate any small vessels, and it is kills anaerobic organisms. And then we put Surgicel as hemostat. Okay. So, histopathology, Dr. Fossa.
Assalamu alaikum. I'm Dr. Hussam Abu Farsakh. Before we start, we'd like to congratulate Dr. Ibrahim Sbeih on graduation of his son from Georgetown University, Aziz. Can you stand, Aziz? Can you stand before? He graduated from politics and finance this year.
His fiancée.
Yeah. Well, I don't know what this is.
Fiancée, please stand up. Gabby is from Spain, and she's fiancée of Aziz, and my daughter, Russia.
Before we talk about TB, I like to tell you that as a pathologist, I see TB in many organs, not the brain. The brain probably is the least that we see. because I do a lot of fine needle aspiration. I see TB not infrequently in the lymph nodes, cervical lymph nodes, and the most common scenario in these patients usually is a housemaid that works in Jordan, usually from Southeast Asia, and it's not uncommon to see enlarged lymph nodes that refer to me suspected of lymphoma, and it's very common to see TB in these lymphadenitis. And the most common question usually asked by me in these cases, is this infectious to the kids? Because most of these housemates care for the kids. Usually this is not infectious in the same degree as open or pulmonary TB. Probably Dr. Muntasir can tell that. The other one that also many people, they don't know about TB. In Jordan, I see about 4 to 5 cases a year of TB in the breast. And usually these cases present as a breast mass. And one caution, when the surgeon usually open these cases, not send them to fine needle, the scar that is opened will become discharging and an ugly scar after TB. This is one thing that can tell you this, but when you refer to me that this is a TB, because the scar of TB never heals, and when it heals, it heals really after bad repair. Let's go to our case. This is a case that we saw many granulomatous diseases. We called it multiple non-caseating granuloma. You know, TB is known for its caseating granuloma, but also TB can cause non-caseating granulomas, especially if it is miliar TB. So don't wait for caseation to call it TB. Many TB cases that we see are really non-caseating granulomas. This is, you can see the granulomas. This is a cerebellar tissue, and there are 3 granulomas in here. One of them near the blood vessel, you can see it more. You can see this is the granulomatous disease. This is miliary, typical miliary TB granulomas, lymphocytes, and these are histocytes with many giant cells. You can see some giant cells, and these are the histocytes. The histocytes usually become in whirling pattern. And you can see this is cerebellar tissue, you can tell, and this is granuloma in here and granuloma in here, and this is cerebellar tissue. So now we are in the cerebellar tissue, and all these are granulomas, multiple granulomas, many of them. Some of them, they are really around blood vessels. This makes you to think of other differential. I think always pathologists, when they diagnose a case, always have to think what really it could be else. This is a granuloma around blood vessel. You always have to ask yourself, is this a granulomatous vasculitis, or this is a granuloma secondary to TB? Because TB granulomas can be around blood vessels, but also other granulomatous diseases like Wegener's or Church-Strauss or other things can be around blood vessels. You can see here the blood vessels, and here is the granuloma around it. This is the multinucleated giant cells. The giant cells that are present in TB, we call them Langhans type giant cells. The nuclei are usually spread at the periphery of the nucleus. Many nuclei together, merged together, and form large cells, and the periphery are formed by Langhans type giant cells, in contrary to the foreign body giant cells, which usually the nuclei are scattered all over the giant cells, not in one line, as in Langhans giant cells. We did Zell-Nelson for this case. Zell-Nelson was negative. I warn you, don't dismiss TB if Zell-Nelson is negative, because really Zell-Nelson, in my hand and many other people's hands, I think it's less than 10%, especially in miliary TB. We do also, when there is granuloma, we have to do all our infectious stains workup. We do GMS stain, global methylamine silver stain. This is for fungi. We do BS stain. This is for fungi and parasite. We do GAMS stain for parasites. So we work up everything to call it whether organisms are seen or not seen. And this is usually is really very tremendous work when the pathologist has to spend looking for or searching for Zell-Nelson stain. Probably one slide will take him 1 hour to search for Zell-Nelson stains. It's not an easy task to look for Zell-Nelson stain. So we call this case as a granulomatous lung disease. We advise to do some stain. This is a test, adenosine deaminase, and some other test for TB. We have a new test, not interferon, we call it T-spot or Oliospot test. Actually, Oliospot test is more common in Britain than in United States. Interferon is more. I have in my lab the Oliospot test, which is very good test. really to look for active TB. So this is granulomatous lung disease, granulomatous brain disease.
Is Dr. Bijani around? I've seen him. No, he's left. Okay. So the postoperative course, the patient was awake on table. We don't allow patients to go on ventilators. They must get awake on table. No one should leave theater unless they are awake. They are not awake, there's a problem, and we need to know it there and then. So we do also the brain MRI the very following day. Even if we finish at 3 a.m., the following morning at 7 a.m., he must have the MRI. So that's the MRI. That's where we are.
PCR tissue.
Yes, it was negative.
PCR.
Yeah. So these are the ones that Dr. Fossa asked for. The serum adenosine, negative. TB60, negative. Dr. Muntasar Balbisi asked for serum TB quantiferon and sarcoidosis enzymes, and they turned out to be normal. Angiotensin was normal for sarcoidosis. So we started the treatment on the basis of the histology, that this is a granuloma and this patient is coming from Yemen, and he was started on the treatment as in rifampicin, pyrazimide, and levofloxacin. This was for 2 months, and then this was for 1 year. Isoniazid, rifampicin, and vitamin B6. Patient was doing well, and he was discharged on the 7th postoperative day. This is him, showing you that he has full eye movements, that he was mobilized immediately after surgery. And this is our famous by now discharge summary, made of 15, 20 pages, whatever, telling everything about the patient, everything we have done, pictures, everything. This is follow-up in the clinic. Again, he's doing well, and this is his follow-up MRI, 6 months, almost cured. No hydrocephalus, fourth ventricle is opening up, cerebellum is okay. And this is 1 year follow-up. Again, no trace of the disease. So it's learning the process that we take from the day we are born till the day we are die for thousands of years. If you stop learning, you will be missed. Thank you very much. Can I answer the questions? Please.
This case, you said that stain was negative, counterferon test negative, PCR is negative, yes? And you put the patient on for anti-TB medication. So how do you diagnose it?
Because this is a granuloma from Yemen, most likely, and I leave this to Muntasar to answer.
Yeah, Dr. Muntasar, you remember we had a case like this where all the tests was negative. One patient I sent it to you. Okay, but Dr. Hussain said that this patient has a granulomatous disease, but I can't say it's a TB. And we put the patient on anti-TB or where all test is negative.
This is the problem with TB. How do you really diagnose it? Oftentimes these smears and PCR are not sensitive enough. Based on the clinical presentation, based on the actual non-caseating granuloma described by Dr. Abu Farsakh, based on the fact that this is a Yemeni patient where TB is endemic in Yemen. There's an old adage, there's an old pearl. If you ever think of a cranial TB, treat it. That's what our professors used to teach us. And so we opted to treat this patient. There was a very high likelihood that this is what he had. And you cannot always rely on it, but what else could it have been? If it was sarcoid, would not have responded to anti-TB medications.
And maybe it's multi-drug resistant, and we're not diagnosed it.
Now,
patient become more worse.
right, you would have to continue to follow the patient up clinically very closely. If this was MDR, then you might expect a relapse or a regrowth of the
Possibly
granuloma.
another biopsy or something.
Yes.
Okay, Dr. Jalil, have you seen TB meningitis in Jordan, in children?
Not in the past 20 years. Myself, I did not see, but we used to see before.
So not in the last 20 years.
No, I did not see. They might go to some other doctors, but myself, I did not see. But we do give the BCG early. As you said, we used to see TB meningitis in children. This is our most worry, you know. But of course, anybody that comes from the neighborhood and they have cough and so on, we do test for TB, but I did not see myself except the meningitis. Did I send you any patient like that and I forgot? Montasser? No.
No, I was going to add, now that you mentioned that they might go elsewhere, there is in Mafraq a TB sanatorium, Masah al-Noor, and it's under the auspices of an American charity group. And they have drugs for MDR TB. They have better diagnostic capabilities, including PCR. And so a lot of people might go to them, like you alluded to.
I'm not saying it doesn't exist. It exists, but in my clinic, I did not.
Okay.
But we really worry about meningitis in children, and that's why we keep on, although the BCG is not the best, but it keeps us more at ease.
So BCG is good, but it does not...
as it was said, 1 year of age, and this is the time that immunity is going to go.
Dr. Junaid, have you seen TB, enteritis? Or?
Yes, I have seen peritonitis, and it kind of presents, there are two ways where it would present. It's called the dry abdomen and the wet abdomen. And they have the dry, you have what you call the doughy abdomen. And you do the laparoscopy, and you would see all the TB and miliary type of TB involving the whole visceral, postperitoneal, and the viscera also involved in that. And they do well on anti-tuberculous therapy after that. Yeah.
Dr. Anwar, any
just comment one more thing that mentioning about the helpers of home that come from South Asia. We have a lot of panic that comes to families once a week at least, when all these helpers should have been examined well, and they would suddenly find after 1 year that they had something, you know, an old TB, and it will be the scare of their life. This is what we worry about children. Thank you.
Dr. Anwar is the senior radiologist.
I have seen TB in, you know, because we used to do all the routine, all the patient X-rays. We saw TB in the bones, in the spine, and in my practice in mammography, I saw in Filipino maids TB in the breast, and I saw one TB in the breast in Jordanian, and sometimes they present as if it is they may mimic anything like heart failure, like anything. And too much we used to see in the chest, because we used to do surveys when لما كان في تجنيد, and we had people coming. We saw small microfilms or small films, and we used to pick up a lot of TB.
For military service.
For military service, we picked up a lot of TB. Now we are seeing in Syrians, actually. Thank you.
Yeah, hi. Thank you so much for
Can you introduce yourself?
I'm going to introduce myself. Thank you so much for this amazing lecture. I'm Rani Abu Samra, consultant in pediatric respiratory from King's. Right, I'm Rani Abu Samra, consultant in respiratory pediatric from King's College Hospital, London, and from next week I'm going to join Farah as one of the the consultants and Farah, hopefully. Thank you so much. I've got quite experience with tuberculosis in the children, and all of the cases I've seen in England, they're either Indian immigrants from Asia, African as well, and actually the worst were the one from Romania and Ukraine, the one with the MDR. One of the cases as well was congenital TB, which is quite rare, and we published that case as well. In terms of CNS TB, yes, we had one of the 13 years old girl who presented with a tuberculoma and pericarditis. Actually, we didn't pick the tuberculoma, we picked the pericarditis, and she had some Baylor rash. We thought it's SLE. We got so excited, we gave her steroid, and then she ended up with tuberculoma. So she had like anti-TB treatment for 18 months, but she recovered really fully. The interesting thing with children with tuberculosis that they recover really well with TB treatment. Most of them, even the one with horrendous chest X-ray and chest CT, they recover almost completely. Thank you.
Thank you much. Any comments, anything from the audience, please?
Yeah, I guess I want to give Dr. Montasser. I was actually in Emirates in Al-Ain Hospital. Thank you so much.
Yeah, thank you so much. My name is Risha. I was in Tawam Hospital, Al-Ain, Abu Dhabi, and now I'm in Jordan back again. Actually, Dr. Montasser is so much worried about the ideas.
And hopefully you're joining us. Yes?
Hopefully. Dr. Montasser is so much worried about the idea sensitivity of TB. Actually, in Emirates, in Abu Dhabi, and in Abu Dhabi, there are two main reference labs for ID sensitivity, where you can get the mycobacterium up to species and you can get a full sensitivity test. This will be very helpful. In Jordan, we can do this actually. Nowadays, there is a midget machine and there are some other, like Vitek, that can help in for ID sensitivity of TB. That's what I want to say. It can be done here very easily.
And what's the turnaround time?
Well, like 24 hours only. Yes, 24 hours. Yeah. That's it. So that we can start the year.
Dr. Khalid, spending some time in USA, have you seen cases of CNS TB?
No, I haven't.
You haven't. Anybody from USA has seen cases of CNS TB? Okay, any more questions or comments, please?
So, listen, on steroids, the patient steroid for how long?
Right. Use of steroids in tuberculosis is controversial. But the tide is towards using it rather than not using it. As you know, one of the complications of steroids is that it flares up infection. So it is said that if you give it to TB to flare up the infection, but most of the people feel that the edema and the well-being of the neurons is good for the steroids. So use it as long as you need, so long that you don't have complications. But usually it is for a few weeks time.
And we had a slide in my talk on that.
Yes, you did. You did. Any more questions or comments? Yes.
I want to ask last two questions.
Last question.
Last two questions. First one, okay. Many of these cases, the surgeon will not know this TB before operation. Yeah? So, we work in tuberculoma. Does the staff in the operating room and the surgeon exposed, or considered as exposed to TB and need some prophylactic antibiotic? This is the first one.
So if you aerosolize these mycobacteria, you are at risk of catching TB. If you have any inclination that this would be TB, it's preferable to wear N95 masks.
Does this mean we won't use some prophylactic antibiotics or do some tests for the staff?
Not really.
No. The second
Open
question.
cavitary TB is a lot more contagious.
Sure.
Much of this is.
محمود راسع خليك شوي.
Yes. Second question. What about spine instrumentation and case of spine? Yes. This question for
Okay.
infectious and Dr. Ziad. Dr. Ziad, in case of spine instability, okay, if in case of spine instability due to Pott's disease, we need to reconstruct the spine in way forward. Okay. Now, use the instrumentation in the presence of TB or pyogenic abscess that lead to instability. We learned that don't use instrumentation because of infection and
it's will become resistant, you will not.
Okay, so the question about instrumentation in TB.
Excellent question, actually, and I was expecting somebody to ask about it. In 1998, I have been in Istanbul for Turkish Swine Society meeting, and there was a full symposium about that. At the beginning, they said, that, or let us say the classical rule that don't put implants in any case of infection, even like when you are talking about fractured femur and so on and so on. You have to remove even the implants, okay, when there is infection after operations or something like that. But they found that, from series of cases and a lot of research about that, unless you stabilize the spine, the infection will not improve. So we went a step forward that, as you see in some cases, these are all old cases, that, we go anterior, remove the whole pathology, vertebra, discs, and so on, and drain the abscess and clean and so on, send it to the culture, and of course we give antibiotic immediately during the operation, and go from posterior, clean area, we put the stabilizing vessels. But actually we found that after some time, recently, we remove everything, and we put cage from anterior, and all from anterior. Sometimes we put cage and plate rods from anterior, and you could not find any difference in the results. But this is conditioned by removal of all the pathological tissues, the vertebra, the discs, and the
before we go, lots of you congratulated me for the success of my son. So I'd like to call upon him so that you can congratulate him personally. Aziz,
لا استنى وين المناسب؟
later.
ما بتزبط ولا راح ما راح نقول مبروك الا بالدار.
Thank you.